My name is Mercy Nyakoa. Sorry for that. My name is Mercy Nyakoa. I work for National AIDS and STI Control Program. The reason why, basically World Hepatitis Day is an annual event that takes place on 28th of July every year. And basically we bring together people across the world to just raise awareness about hepatitis being a global burden and to ensure that we advocate for significant change. During this day, it's simply a way of uniting partners and also the public to ensure that we are able to take action against hepatitis as a major public health threat. Why do we celebrate World Hepatitis Day? We are aware that when you look at the global report, very few people living with chronic hepatitis have been diagnosed, meaning they're not even aware about their status. And globally, it's around only 13% that have been diagnosed and only around 3% that are on treatment when it comes to hepatitis B. On the other side, when you talk about hepatitis C, only 36% living with chronic hepatitis C have been diagnosed, and only around 20% have received curative treatment, meaning it's important that we continue raising awareness about viral hepatitis so that people are aware of their status, as well as seek the relevant information with regards to treatments. So I know those of us who live in Kenya, Kenya is also endemic of viral hepatitis, and being endemic of viral hepatitis, it is critical that we continue raising awareness among our teams so that they seek for screening services and also they're linked for early treatment as a way of prevention, and also ensure that there's minimal transmission across the board. So today we are having members who are going to just take us through awareness of hepatitis B. And on the panel, we have Dr. Nazila Ganatra. Dr. Nazila Ganatra is the viral hepatitis manager within the Ministry of Health. So she's basically leading the viral hepatitis issues in the country to just ensure that she collaborates policy implement. She's also oversees that the healthcare workers have training. Specifically for today, again, we have our own Dr. James Wagude, who will be taking us through the viral hepatitis prevention and treatment for hepatitis B. And Dr. Wagude is a consultant physician. He is currently working with the Department of Health in the county government of Siaya, and he's based at Siaya County Referral Hospital, which is in Kenya. I just want to let you know that Dr. Wagude is an alumni of the Master in Internal Medicine course from University of Nairobi, and also Arthur Ashe HIV/AIDS Fellowship from Well Medical College of Cornell University, New York, United States of America. He has a vast experience in HIV, tuberculosis, and viral hepatitis, together with STIs. He's currently pursuing a postgraduate diploma in diabetes at the University of Wales. And I just want to let you know, Dr. Wagude is a chair of the Nyawest Clinical Regional Technical Working Group that is committed to improving the quality of HIV care and mentorship to healthcare workers in 10 HIV tuberculosis burden counties within the Western region. Also, Dr. Wagude, being a technical expert, he provides quite support to the National AIDS and STI Control Program in Kenya as a member of both the HIV and also viral hepatitis and STI technical working groups, in addition to also supporting national tuberculosis, leprosy, and lung health program. So with us, we have quite the best person to just take us through issues around viral hepatitis, considering that we are working in an era of integration and also comorbidities with these other diseases are real. So I want to welcome the panelists on the speakers on board to just say hi, even as we start the session. Thanks.
Hello, everyone. Can you hear me, Mercy?
Yes, I can hear you.
Okay, thank you. Great to be here.
Was I audible?
Yes, very clear.
Okay. Starting with Dr. Nazila.
Good afternoon, everyone. My name is Dr. Nazila Ganatra, Program Lead for Viral Hepatitis and STI, working at NASCOP, that is the National AIDS and STI Control Program at the Ministry of Health, Kenya. Karibuni sana. Thank you.
Thanks so much, Dr. Nazila. Dr. Wagude, please say hi.
Hello, everyone. I'm Dr. James Wagude, working with Siaya County Referral Hospital and technical advisor in NASCOP and the TB program as well, the viral hepatitis and STI program. Thank you.
Okay, to start us off, we are going to start off with Dr. Nazila, who is just going to provide an overview of the viral hepatitis program and just let us know what are the country's plan in relation to viral hepatitis in the country. Thanks, and over.
Thank you very much, Mercy. So just to provide an overview of what the viral hepatitis and STI program is currently doing. And why it is very important to actually inform all our stakeholders and healthcare workers on where we are at with regards to viral hepatitis. So first of all, the national program is working on integrated guidelines in the spirit of integration and sustainability. We are working on integrated guidelines, which actually integrates HIV, STIs, and viral hepatitis all in one document. It will be a very simplified document, which will be able to assist healthcare workers to be able to, be guided by those documents all under one very comprehensive document. The program is also separately working on a more detailed standard operating manual, which will be able to provide additional information for healthcare workers if they so need. And the detailed standard operating manuals are actually 3, which we are working with currently. There'll be a standard operating manual for viral hepatitis, standard operating manual for STIs, and a standard operating manual for triple elimination of vertical transmission of mother to child of both HIV, syphilis, and hepatitis B. Following those documentation launches, we'll also be having training, because we do note that viral hepatitis and STI trainings and information is really lagging behind, especially with healthcare workers. So it is very important to be able to train and capacity build our healthcare workers for us to be able to achieve eliminate our elimination goals. We are also in the process of recruiting or identifying a few counties where we shall be able to try and see if we could be able to do modeling pathway of care to see how integration best fits within HIV and STIs. So that is what we're currently working on, and really happy that we are here today to be able to commemorate the World Hepatitis Day, which will be held on 28th of this month, that is on Monday at Mombasa County. And we wish to see everyone there. And this webinar is very key because we are creating awareness for hepatitis B and ensuring that no one is left behind. Thank you very much, and over to you, Mercy.
Yeah, thank you. Thank you so much, Dr. Nazila. And now we just want to dive into the webinar itself, and I hence hereby welcome Dr. Wagude, who is going to take us through. Asante, if you have any questions, please put them on the chat. We shall note them down and they should be able to respond to you. Thank you so much, Dr. Wagude.
Thank you, Dr. Nazila. I hope you can hear me, Mercy, as I get ready to share my slides.
We can hear you, Dr. Ari, thanks.
Okay, let me know if the slides are now showing.
Yes, they are.
Excellent. Okay, so make them PowerPoint view. Are they in slide view?
Yes,
Hello?
thanks. Yes, thanks.
Okay, so thank you. I think I'll proceed. That's my outline. I'll look at the case studies, talk about the epidemiology of hepatitis B, a little bit on virology and transmission, and then talk about the algorithm in adults, adolescents, and in pregnancy, as well as infection with other diseases and conclusion. So if we can start first, I'll start with a 26-year-old, a female who presents at 32 weeks gestation in the NC clinic. She is found to be hepatitis B positive. She's otherwise well, and the baby is well. She's HIV negative, and the doctor recommends test for hepatitis B DNA levels, but she's unable to afford the test. She's thus advised to ask relatives for help raising the money for the test that the doctor has asked. Do you think that the doctor should go ahead and offer antiretroviral treatment anyway to prevent transmission? Please share your thoughts on the chat. And for how long should the doctor treat the patient as a form of transmission to prevent transmission? If you would, you could kindly share your comments in the chat. So we'll come back to that. Case 2, a 28-year-old female presented to the labor ward in active labor. An NC profile is done and she's found to be hepatitis B positive. She's HIV negative. On assessment, she's well and has no stigmata of chronic liver disease. She then proceeds to deliver a live female infant. Both mother and baby are well. And the gynecology team calls to consult on whether what to give the baby for hepatitis B prophylaxis and whether the mother will need treatment now that she's breastfeeding her child. Any thoughts on that? Again, let's look at the chart. Would any of you recommend giving prophylaxis, and what would we give? And also the question of what do we give the mother? Do we need to give the mother treatment now that we know she'll be breastfeeding her baby? So I can see most people are saying yes, you'd start treatment. The other case, and for this case, I don't see anyone yet. Most people are responding to the first case yet. And just go back. Yes, so I can see there's a lot of thought about giving treatment, but it's something very important to think about in terms of preventing transmission. Okay. Good. So thank you for your comments. For case 2, case 1 is well answered. Yes, we should give a prophylaxis to prevent transmission. And for how long, we'll discuss that in our seminar. And for case 2, we will give that hepatitis B vaccine at birth for the infant, and we recommend hepatitis B. We recommend hepatitis B prophylaxis in immunoglobulin administration. So case 3, a 25-year-old man came to the donate blood recently. He was essentially well, and screening tests done showed that HIV was negative, hepatitis B surface antigen was positive, its hepatitis C virus test was negative, and VDRL was negative. He has been referred for further workup and management and is otherwise well, no complaints, no comorbidities, and only drinks alcohol occasionally. On further history taking, he's not aware if he received a hepatitis B vaccine in childhood. He can't remember that. And remember that KP started offering this in 2002. So it might be a bit beyond his time. Currently, he's unemployed and unable to afford too many tests. And the tests done shows the hemoglobin was 14, the white cell count was 6.4, and platelets was 150. LFT's ALT was 45, and ALT was 45, and AST was 136. How do you go about the decision to treat or not to treat? So anyone with any comment in this case? I'm looking at the chat. How do we decide on what to treat in this case? So I can see someone saying hepatitis E antigen and viral load, and others talking about an APRI score. So that's really important. And
Wagude, kindly raise your voice a bit. I've seen some chats.
okay.
Someone requesting you raise a bit. Thanks.
Okay, let me increase my volume and just see if you can hear me. So just
You are
increase my
too
volume.
soft, though.
You can hear me now? Let me increase the volume on the device. I hope you can hear me now. Is that better?
Yes,
Okay,
yes,
good.
yes. It's better now. Thank
Great.
you.
So in case 3, people are talking about treat but don't donate blood for now. And repeat the pre-score and repeat hepatitis B surface antigen in 6 months from someone else. So let's just go a little bit into this as people contribute. So thank you for your comments. So yes, I would do an pre-score for case 3, and this is how we calculate it. There are tools online which can calculate it. And basically, you calculate the level of AST according to the platelets, and you get the ratio of the index. And the score, the lower the score, less than 0.5, the greater the negative predictive value and ability to rule out cirrhosis. If it's a higher score, more than 1.5, that gives it a greater positive predictive value, and you can now predict that the patient actually has cirrhosis and needs treatment for hepatitis B. So this patient in this case would have a score of 2.26, and that would mean that we need to treat the patient. And the fibrosis 4 score also is important if you can do it. Again, you take the age, the AST level, the ALT level, and the platelet count. So you can use all those 4 measures. If it's less than 1.45, it has a negative predictive value of 90% to rule out advanced fibrosis. And a FIB4 score more than 3.25 would have a 97% positive predictive value of 65% cases being advanced fibrosis. So in our case, this patient has a FIB4 score of 3.38. So again, we would probably lean towards putting him on treatment for hepatitis B. So if you look at the epidemiology, the prevalent causes of chronic hepatitis B by WHO region over the in 2022, you can see this is widespread mainly in Africa, where we have about 64 million cases, and also if you look at South America, quite also a number there. In the Americas of 5 million, but most of these cases are in Asia, especially Southeast Asia and Africa, and a few in the West Pacific region, like 6,000. So we are one of the high burden regions of hepatitis, and we really need to be thinking about that in screening our patients. In 2022, 13% of the 54 million people with chronic hepatitis B were diagnosed, with only 3% treated. So there's a gap in treatment. And as you can see in the coverage, Africa has quite a treatment gap of about 5.5% in terms of coverage to end of 2022, as well as a Western Pacific region. So we are suffering that not enough patients have been picked up for hepatitis B testing and also on treatment. When you also look at the regions that have poor coverage, again, if you look back at Africa, only 5% treatment coverage among all people who are diagnosed at the end of 2022, and 0.2% treatment coverage among all patients with hepatitis B, whether they're diagnosed or not. In terms of diagnosis coverage, we're also very low at 4.2% at the end of 2022. So we really need to improve and look for cases and put them on treatment. And the prevalence, if you look at the high prevalence countries, you can see Southern Africa is really high, and also Kenya, Tanzania, and Uganda are not left behind. So it's something that's worrying us in terms of coverage. If we look at virology of hepatitis B, we know it's caused by an enveloped DNA virus, which is the hepatitis B virus. Hepatitis B virus infection can either be acute or chronic, and occasionally it can be an asymptomatic infection or mild disease to severe and rarely fulminant hepatitis. Acute hepatitis B is usually a self-limiting disease with a case fatality rate of 0.5 to 1%, while chronic hepatitis B is defined by the presence of detectable hepatitis B surface antigen in the blood or serum for more than 6 months, and this encompasses our spectrum of various diseases. So the age of exposure is a key factor in determining the chronicity of infection, and especially when you get this in childhood, but most of the times in our cases, you are unable to tell when someone really got the infection, and that's one of the disadvantages. If you look at the structure of hepatitis B and virus, you can see the envelope where we usually get the hepatitis B surface antigen picked up. Then you have the core antigen under the envelope, followed by the DNA polymerase that gives it its replication factor, and then you have the E envelopes just down here. It's a very small virus, about 42 nanometers in size. What about symptoms? When you get acute hepatitis B, usually the symptoms are what we call non-specific. It's very hard sometimes to know that you have a disease, but in those who are very sick and get admitted, it's it's a disease that we're supposed to pick up through the screening of the symptoms. Most commonly, you have loss of appetite, weakness, fatigue, headaches. You get hives and skin eruptions. You get joint pains. In the abdomen, you get right-sided abdominal pain with nausea and vomiting. Occasionally, your stool or your urine changes color with the stool with dark urine because of the bilirubin, and a pale stool because of lack of bilirubin pigments in the stool. Occasionally, the patient can get fever, and not all patients will develop with jaundice. So that's something to look out for. So in the lab, once you pick up the symptoms, there's certain tests that we do to pick up whether you are likely to have hepatitis B. One of the first ones and easier ones we do is hepatitis B surface antigen, where the first marker to appear in the course of the infection, is the hepatitis B surface antigen. This appears 1 to 3 weeks before the onset of symptoms. And as I said, if this marker lasts more than 24 weeks or 6 months, it indicates chronicity. In our case, usually most times we're unable to tell when the patient got infected unless they were admitted and tested during the acute phase. Other markers of recent infection include anti-hepatitis B, core and IgM and IgG. So IgM is a mark of recent infection and appears with the onset of symptoms and lasts up to 32 weeks after infection, while anti-HB, core antigen IgG, does not indicate immunity and is not elicited by vaccination, just shows you that there was prior contact. For hepatitis B, envelope antigen, A antigen, it appears before the onset of symptoms and indicates viral replication independent of disease phase, whether it's acute or chronic. And its presence indicates, and that's one of the things you have to look out for. The presence actually indicates, so for anti-HBE, the antibody to HBE, its presence indicates high infectivity. It typically appears after disappearance of hepatitis B E antigen, and the presence reduced reduction or absence of viral replication, and except when infection is due to HBV strains with pre-core mutants which are not producing the protein E antigen. Then lastly, we have anti-HBs, which appears 1 to 3 months after HBV vaccination or after recovery of acute infection with HBV, and it usually indicates long-lasting immunity to hepatitis B virus infection. So typically, when you do the test, you start with hepatitis B surface antigen. Then when you want to look for those that you might have missed, you can actually add on the anti-HBC and antibodies and confirm whether someone is immune when they have those positive by doing an anti-HBs. So in terms of transmission of hepatitis B virus, this can be percutaneous or mucosal, exposure to infected blood or blood fluids, including saliva, menstrual and vaginal discharges, seminal fluid, colostrum, and breast milk and serous exudates. You can also have accidental inoculation of minute amounts of blood or fluids during medical, surgical, and dental procedures. Sharp objects of contaminated infected blood can also cause transmission, as well as in poor use of inadequately sterilized syringes and needles, as well as intravenous and percutaneous drug abuse, tattooing, body piercing and acupuncture, and sexual transmission. Other forms of transmission include the vertical mother-to-child transmission, where the greatest risk of developing chronic infection, usually following mother-to-child transmission, is up to 6 months. That's at about 90%. Later on, this decreases to about 30% between the ages of 6 months to 5 years. Mothers who are seropositive for hepatitis B E antigen and those who have high HPV DNA levels in blood, more than 200,000, are at higher risk of transmitting the infection to their infants in the absence of prophylaxis. Although hepatitis B virus can infect the fetus in utero, this is rare, and transmission is generally associated with the antepartum hemorrhage and tears of the placenta. Hepatitis B virus infections also tends to cluster within families, and that's something we've noticed in Kenya, with some counties particularly having higher prevalence than others. In terms of testing, an invasive test to assess liver fibrosis, which is a complication of hepatitis B, Commonly used non-invasive tests include the following ones: the APRI score, which uses AST and platelets, and one of the simple ones for our setting, as long as you can do a hemogram and a liver function test. FIB4 adds to this, where it also adds the age and ALT to the other two tests that I've mentioned. These are simple serum immunology tests, and the cost is relatively lower than the rest that I'll talk about. Fibro test is a more accurate test of looking for liver cirrhosis and fibrosis. This involves utilizing GGT, haptoglobulin, bilirubin, apoprotein A1, and alpha-2 macroglobulin tests. But these are specialized tests which are not common in our county referral hospitals and are done at specialized and designated laboratories. So the cost is much higher. Lastly, this fibroscan is a specialized ultrasound which looks at transient elastography of the liver, and the equipment are usually dedicated and need specialized care, and the cost accordingly is much more higher. So those are the tests that we can use to just tell us whether the patient needs treatment due to the presence of liver fibrosis. In terms of clinical features of advanced liver disease, again, and cirrhosis that determine whether someone needs treatment, you want to look out for features of advanced liver disease and cirrhosis like hepatomegaly, splenomegaly, itching of the skin, that's pruritus, severe fatigue, joint pains like arthralgia, pulmonary edema where the palms are red, and edema, swelling of both legs. When the patient gets into decompensation, then you find features of portal hypertension like ascites, hematemesis with variceal hemorrhage, and hepatic encephalopathy, which comes with confusion and sometimes severe coma. You can also have coagulopathy and bleeding disorders, and last but not least, you get liver insufficiency, and this is present with jaundice and inability to break down drugs and other features. Then you have what we call progression of liver fibrosis, which can be staged by the metaviric fibrosis staging. And this usually is defined as F0 all the way to F4. As you can see in the infographic, F4, the liver doesn't have fibrosis, while in F1, there's initial fibrosis with portal fibrosis without septation. F2 is intermediate fibrosis, where you have portal fibrosis with septa forming. And F3 is where you have numerous septa without cirrhosis, which that becomes a bit advanced. And then the last stage is basically known as cirrhosis, where the patient has outer fibrosis and nodular degeneration and quite distorted architecture of the liver, as you can see in the infographic up here. So those are the stages again of liver fibrosis, where you want to stop the patient advancing as early on as possible to the last stage, which is cirrhosis, because that stage you need to either do a liver transplant because there's no other form of treatment. So again, just a reminder of the calculations. There's the EPRI calculation where you use the high AST and you divide it by the upper limit, upper limit normal of the AST, and you also divide that by the platelet count. The FIB4 stage, which uses the age, the AST level again, and the platelet level, and as well as the ALT level. So for this, both of these calculators, which look at trying to assess how much fibrosis there is, if you can't do the ultrasound, they are online calculators easily accessed at those stages. So that's very important. Okay. So the next step is treatment and assessment for treatment and treatment. So I want to just change my second. I just want to change my bed. Change the that I'm using. Good. Please confirm that you can hear me still.
Yes,
Mercy,
Doctor, we
still
can hear
me?
you. We can hear you.
Okay, great. So let me continue. So in terms of assessing people who is eligible for treatment, that is one of the new things that the guidelines now have simplified compared to the past. So when you initially assess your patient, as long as you've gotten someone who is hepatitis B surface antigen positive, you need to determine if that patient will qualify for treatment on their own, whether they're pregnant or not. So these are the things that we need to have available for the assessment of treatment. You need to be able to do the APRIS test at least, or if you can do the FibroScan would be good to assess the severity of liver disease. You need to do an ALT and a hepatitis B virus DNA if possible. Take a good medical history looking for core infections like HIV, hepatitis C or hepatitis D, comorbidities like diabetes, steatotic liver disease, immune suppression, someone who's on long-term use of steroids or transplant, extrahepatic manifestations like kidney disease, glomerulonephritis, or autoimmune disease like vasculitis, or if there is family history of cirrhosis and liver cancer. Then you also think about general measures of lifestyle, cancel them and stopping alcohol, improving their diet, and having physical activity. You also need to prepare them for treatment through adherence support, through the individuals and their family members who can support them, identify any risk factors for renal dysfunction, and do a baseline renal function test if you're going to use tenofovir. You also want to do preventive measures such as hepatitis B surface antigen screening of family and household members. Sexual contacts as well should be screened for hepatitis B surface antigen, and you vaccinate those who are negative. So once you've done that screening, you can now look at who qualifies for treatment. We want to treat, guidelines generally recommend from WHO that we treat all adults and adolescents above 12 years, including pregnant, non-pregnant women and girls of reproductive age, with the following issues: significant fibrosis more than F2 or cirrhosis at F4, regardless of HBV, DNA, or ALT levels. And that's if you have any of that, like clinical criteria of cirrhosis, through the APRIS score more than 0.5, or you have FibroScan and it gives you a score more than 7 kilopascals. This will now show that you qualify for treatment. Or second criteria is if you have hepatitis B viral DNA more than 2,000 and an ALT level more than upper limit of normal. Both those are positive, then you can start on treatment. Or presence of any of the following, whether your score is good or not, or you have your hepatitis B DNA is normal or not, or ALT is normal or not. If you have either HIV, hepatitis C, or hepatitis D, you must treat. If there's family history of liver cancer, cirrhosis, if there's immune suppression, if there's comorbidity, if you're diabetic, if metabolic dysfunction associated with steatotic liver disease, or if you have renal issues like glomerulonephritis or vasculitis, you must start on treatment. And the last indication, in absence of access to HBV DNA assay, if you have persistently abnormal ALT levels alone, then you can start on treatment. So what are the contraindications to treatment? If your ALT is persistently normal, you go ahead and do a DNA and it's less than 2,000. There are no co-infections or comorbidities. Then those patients, you can defer treatment and monitor their levels over time. So again, to remind you, if you can't do DNA and ALT, you can simply calculate the APRIS score and see if the patient qualifies. And that has simplified the treatment in our current regimen if you're HIV negative. So what treatment can you offer someone who qualifies for treatment? You can use tenofovir alone or ETV. You can use tenofovir plus 3TC or TDF, tenofovir plus FTC if you have no access to TDF monotherapy, which is pretty much in our setting because most of the tenofovir we have comes from the HIV program and is co-formulated with lamivudine or emtricitabine. That's 3TC or FTC. You can use FTV or TAF on its own in persons with osteoporosis or impaired kidney function, or in children and adolescents that can't qualify using TDF. So these are the preferred first lines. You have entecavir or tenofovir, that's disopril fumarate, that's TDF. For adults, adolescents 12 to 17, you can use TDF and entecavir. And in children, the recommended drugs are low dose of TDF or etecavir again. The alternative first lines are TDF plus 3TC or TDF plus FTC, where you can't give monotherapy in adults and then also in adolescents, but we don't have such alternative in children, unfortunately, because of the age group limitations. For special circumstances, you can use monotherapy with ETV or TAF for people who have established osteoporosis or renal dysfunction that can't use tenofovir disopril fumarate. So in children and adolescents, we use the weight-based dosing in that ETV can be used below 30 at 0.015 milligrams per kg once a day to a maximum of 0.5. If you are above 30 kgs, you can use 0.5 milligrams once daily. For TDF, above 2 years, you can use, if you have the formulation which is their syrup, you can use 8 milligrams per kg once daily up to a maximum of 300. Above 12, it's easier because you can use that 300 milligrams once a day, and or even above 30 kgs. TAF can be used with 25 milligrams once daily, above 12 years again. So it's important to know that the TDF has been approved for children 2 years or older with chronic hepatitis B, for weighing at least 10 kgs for both guidelines, and for TAF for 6 years and older, but have to weigh more than 25 kgs. For EMA, European Medical Authority, and FDA have said 12 years and older if you have compensated liver disease. When we have patients with renal failure, that becomes really tricky, especially with the compensated cirrhosis. So you have to reduce your dose or give dosing intervals. So for tenofovir, again, it's something that we want to be careful below 50 mils per minute, but above that, you just use 1 300 milligram tablet once a day. Below that, you have to now use reduced doses, 1 tablet every 48 hours for 30 to 49, for 10 to 29, 1 tablet every 72 to 96 hours, or 60 milligram scoops of powder every 24 hours. Less than 10, again, use 1 tablet every week, once every week, or after every 12 hours of dialysis, or a scoop of 20 milligrams after completing dialysis every 12 hours of dialysis. Most of the time, we tend to avoid tenofovir less than 50 kg, so we do have TAF available, and that might be a better option now. ETVR can be used, but you have to renal dose it again in renal failure, as you can see, 0.25 once a day for 30 to 49, 0.15 milligrams once a daily, or 0.5 every 3 days, or 0.05 in hemodialysis, or 0.5 once every week. So that's the recommendation. So once you've started on treatment, remember this treatment is lifelong. Anybody who is qualified for treatment, you don't stop the treatment because that would cause a flare. So if someone is put on hepatitis B virus treatment, that must be continued for life. Every 6 months, do surveillance with alpha-fetoprotein and ultrasounds in those who have cirrhosis or family history of cancer. And every 12 months, check for response, check on adherence if on treatment, do non-invasive tests like APRI or the ultrasound scan, monitor ALT and hepatitis B viral DNA if you can, and please check on the renal function, especially if they're on a tenofovir or TAF-based regimen. Very important. That's once every 12 months. So that, remember I said again, and I'll stress, that should continue for the rest of their life. You cannot stop it because of the risk of a flare. So that treatment is lifelong if once they qualify. What about algorithm for prophylaxis for PMTCT in pregnant women and adolescent girls with chronic hepatitis B? You must also think about checking the eligibility of their own treatment as you give prophylaxis. So in pregnant women and adolescent girls, we must do hepatitis B surface antigen testing early in pregnancy. As early as possible is the best thing to do. If the hepatitis B surface antigen negative, that is good, then we don't talk about it much further. If they are positive, then we need to do further evaluation. So the first thing we have to do is think about, does this lady qualify for antiviral prophylaxis to prevent transmission to the child? So we must assess them for prophylaxis, and if you are able to do hepatitis B virus DNA or hepatitis E antigen testing, you can go on and do it. And if it's more than 200,000 or HBE is positive, then you must start maternal tenofovir prophylaxis from at least the second trimester of pregnancy until at least after delivery or completion of the infant hepatitis B vaccination series. And I'll come back to that. If you can't do hepatitis B virus DNA or hepatitis A antigen, and that occurs in most of our settings, and that's usually not available in most of our settings, then you must think about offering maternal tenofovir prophylaxis to all hepatitis B surface antigen positive women and adolescents, from at least the second trimester to at least until after delivery. or completion of the infant hepatitis B vaccine, B virus, vaccination series. And please remember, you must give the first dose preferably within 24 hours of birth for that. So if you did do hepatitis B virus DNA and it's less than 200,000 and the patient is hepatitis B E antigen negative, then there's no role for maternal tenofovir prophylaxis. That's the only exception. So remember again, if you can't get both the hepatitis B virus DNA and hepatitis B E antigen, and you can't do both of them, then the patient must get maternal tenofovir prophylaxis. So please remember that. It's also important as you start the prophylaxis to consider, does this mother need to continue prophylaxis later or only for prophylaxis, or do they need treatment as well? So that's really important. So you must take the mother through some steps of checking whether they have qualifications to start on treatment for themselves. So we do the same criteria that this adolescent girl or pregnant woman have significant fibrosis, regardless of your DNA or LT levels. And then if you can't do the ultrasound test, then you do the APRI score or the transient elastography and see if you can score them. Secondly, another criteria is DNA more than 2,000 and LT levels higher than upper limit of normal. Another criteria for treatment again is presence of any of the co-infections, HIV, hepatitis C or hepatitis D, family history of liver cancer or cirrhosis, if they're on steroids for immune suppression or on transplant suppression, comorbidities like diabetes and steatotic liver disease, or extrahepatic manifestations like glomerulonephritis or vasculitis. All those must be considered for treatment. The last one for treatment also is a patient who has persistently abnormal ALT levels alone when they cannot access hepatitis B virus DNA assay. So that also qualifies for treatment. So basically, if that mother satisfies any of those 4 criteria, then she should continue with the treatment and not just prophylaxis. And so she will not stop after delivery or completing the vaccination series for the baby. So that patient must continue lifelong on treatment with antiviral treatment for hepatitis B. For the infant, again, we've said, remember, we must get the hepatitis within 24 hours of birth, followed by 2 or 3 doses of the vaccine later. Very critical. And I think it's a measure of success by checking how many children in your facility got the hepatitis B, the first dose of hepatitis B vaccine within 24 hours. That percentage tells your facility how well you're doing in giving prophylaxis for the infant born to a hepatitis B surface antigen positive mother. So that's a good thing to use. So let's talk briefly about co-infections. Let's start with HIV and hepatitis B. 1% of people living with hepatitis B virus infection, that's about 2.7 million people, are also infected with HIV. And in the other, conversely, the global prevalence of HPV infection in those with people living with HIV is about 7.4%. So that means that out of 100 patients in your facility in your HIV clinic, about 7 patients will have hepatitis B positive. The problem is, though we do recommend baseline testing for hepatitis B surface antigen in all newly diagnosed HIV patients, this is rarely done. And I think we need to leverage on SHA to make sure we push samples and get the test done and recorded in our EMR or in our documents for our HIV patients. This is really critical, and this is really poorly done at the moment. HIV co-infection also causes accelerated progression to cirrhosis and hepatocellular carcinoma, higher liver-related mortality, less spontaneous clearance, higher HPV replication and reactivation rates, and reduced treatment response to the antiviral treatment. So that's something we really need to look out for, and that's why we need to really make sure both these patients are on treatment for both diseases. Luckily, in our guidelines, we usually use tenofovir and lamivudine in a 3-dose combination for HIV infection treatment, and these 2 are also active against hepatitis B vaccine virus. And we do know that there's consideration of newer regimens like the dual oral therapy, like DTM, which involves DTG and 3TC, as well as cabotegravir and ribavirin, long-acting injectable regimens as dual therapy. Before we start any of our patients with HIV on either of these simplification regimens, we must do an hepatitis B surface antigen, because we'd probably be stopping tenofovir, and that may cause a flare of acute hepatitis. So before you move patients to this, when they become available in Kenya, we must do a hepatitis B surface antigen test. And I think we should just be doing that for all our patients. Going forward, if you're going to use dual therapy, maybe one thing we need to consider in Kenya and in your counties, wherever you are, is proposing to the county during the budget that it's something we should think about, vaccinating all our people living with HIV for hepatitis B if they are hepatitis B surface antigen negative. That would make it easier to use the dual therapies going forward if they are vaccinated. In terms of hepatitis B and C virus co-infection, this is at an estimated global prevalence of between 1 to 15%, with this co-infection being complicated because it's associated with faster progression of both diseases, a higher rate of hepatocellular cancer development, and higher risk of infiltrating and aggressive forms of hepatocellular cancer. Typically, also, patients with both co-infections develop hepatocellular cancer at younger ages, and that's something to look at that makes it a bit harder to control. When you have co-infection with both viruses, typically hepatitis C virus replication dominates over the hepatitis B virus replication. Remember, I said the hepatitis B virus is a DNA virus, so it replicates in the nucleus, while hepatitis C virus is a RNA virus and replicates usually in the cytoplasm. So again, this co-infection can be triggered through simultaneous co-transmission, where a patient gets both viruses at the same time, but more commonly it's through superinfection, where a patient already has chronic hepatitis B and then gets superinfected with hepatitis C virus, which is the most common route, rather than hepatitis B virus infecting someone with chronic hepatitis C. So in most cases for superinfection, HCV virus is the new infection that superinfects the other virus. In terms of treatment, when you're treating, you must treat both hepatitis B and hepatitis C to get remission and recovery. And patients who have hepatitis B surface antigen positive require treatment with nucleotides or nucleoside analogs like tenofovir before and after you give directly acting antiviral therapy for hepatitis C. Why do we talk about this? It's because if you don't treat for hepatitis B, there's increased risk of reactivation of hepatitis B for those who are surface antigen positive. So it's very important that you must suppress the hepatitis B before you start treating for hepatitis C. I think with that, I will stop there and we can take any questions. Thank you so much for listening, and I hope we'll be able to do much more better in terms of both preventing mother-to-child transmission and treating all those patients that we have who are hepatitis B surface antigen positive. Thank you very much. Over to you, Mercy.
Yeah, thank you so much, Dr. Wagude, and thank you so much for the members who managed to log into this webinar. As illustrated during the start of the webinar, we requested if you have any questions, please utilize the Q&A section. And I'm impressed. We could see the interest and also from the questions that are coming on board that people have been listening, and we'll just go direct to the questions so that Dr. Wagude can respond to the same. Starting with Mutembe. Mutembe is wondering, when should we stop hepatitis B treatment? Mutembe is asking, when should we stop hepatitis B treatment? Daktari?
So, like I said, if someone qualifies for hepatitis B virus treatment, it's lifelong. Can I emphasize that you treat for life? Rather like HIV, you don't stop treatment, because patients who have stopped treatment will notice that there's a flare. So our current guidelines emphasize that when you treat, this is long-term, you're going to treat for life as you monitor the patient. So for right now, the treatment is for life. Thank you.
Thank you so much, Daktari. And I hope, Mutembe, you are still on the call and you've had the response to that. Then we have Purity. Purity seems to be working in regions where they are quite, the temperatures are relatively high. And Purity is asking, what is the relationship between hepatitis B and hot environments? because she tends to see most of the mothers in those regions turning positive of surface antigen, and she's concerned to just understand the relationship between hepatitis and temperatures. Dr.
That's an interesting question. I don't think there's really a correlation with temperature and spread of hepatitis B. Remember, most of the route is sexual transmission, and so I don't think we found a link. Yes, it's true that hepatitis B is high among the tropical zone. If you remember the map I showed you of the regions with high prevalence, it's in Asia and Africa. But remember, even among the tropical zones of Americas, it's not so high. So I don't think there's really a relationship between high temperatures and hepatitis B, because most of the time you spread this through direct person contact through blood and inflected fluids as well. So I don't think that's a relationship, but it's an interesting thought. But yes, the countries along the tropical regions do have a lot of hepatitis B. But that may be just due to behavior, and especially sexual behavior, rather than the hot temperatures. For instance, in Kenya, I don't really know if it's really high in Somalia and the borders of Somalia compared to, say, cold places like where it's called like Limuru or so. But I don't think we've really seen that as a trend. But thank you.
Thank you so much, Dr. The next question from James. James is wondering whether percutaneous transmission include contact with body fluids of intact skin. James is asking to understand whether percutaneous transmission include contact with body fluids of intact skin. Dr.
So that's a good question. Percutaneous transmission usually involves cut skin, where you have damaged skin. We do know that it's a bit more, it's more transmittable than HIV. So that's something to watch out for, but you must have breakage of the skin. So it's intact skin does not cause transmission like HIV, but you must have broken skin for you to spread from person to person. So that's the thing you have to look out for. Or you have blood transfusion or inoculation into mucous membranes, but not intact skin. Thank you.
Thanks, Dr. for that clarification. We have a member who's registered as anonymous, and they're just wondering, can a client with hepatitis B virus, can clients with hepatitis B virus be cohorted? Can clients with hepatitis B virus be cohorted? If yes, with what?
Okay, I'm trying to look for that just to read that with you, because I didn't get the question. I'm just trying to see where it is. It's in the Q&A. Is that from the Q&A?
Yes, it is in the Q&A. I've actually requested for the person to clarify further, but I've not seen it because I also struggle to understand the question.
Could you read the question again? Because I can't see even the question, so maybe just read it again.
Yeah, so the question says, can a client with hepatitis B virus be cohorted? Because you know the issues around cohorts. Yes, cohorts. Yes.
Cohorts.
Yes.
Is that with other diseases?
Yeah, that's why I requested the participants to kindly help us to understand. However, they haven't responded to my question yet. So
because
we just hope that
the only thing I know about is comorbidities and co-infections. And we've talked about HIV, hepatitis C, and hepatitis D. So those are the three that we really have to worry about with co-infections, and you must put them on treatment.
Cohorts.
I'm not sure what cohort they mean in that case then.
So maybe as we proceed, the anonymous person will be able to just help us to understand the question. But that aside is, we have someone by the name Kelvin. Kelvin is just wondering whether exposure to hepatitis B infection provides natural immunity.
That's a good question. So yes, that's why we do testing for hepatitis B, antigens and co-antigens, because antibodies, because we look for whether you have immunity once you've recovered. Remember, not everybody who gets hepatitis B infection goes straight into chronicity and chronic infection. So some get acute infection, recover, and do build up antibodies. So not everyone has durable antibodies, and that's why you must check whether the antibody levels do provide immunity even after infection. So not everyone gets durable. It's better with the vaccination, because with the vaccination, you combine it with proteins that boost the immune response, and that lasts much longer. So that's really key. Thank you.
And the same question, just as a rider to that question, Kevin would want to know what informs the period of giving hepatitis B vaccine to exposed clients who test negative with a rapid test. What informs the period of giving hepatitis B vaccine to exposed clients who test negative with a rapid test? To you, Dr.
So what exposure is it talking about? The giving it at 0, 1 month, and 3 months? I think that's what he means. If that's what I understand, you're trying to make sure.
Basically, is once someone has tested negative today, for how long should you wait prior to giving hepatitis B vaccine?
So that's the thing. You can start it because once you've tested negative to hepatitis C, you can start the vaccination. So you give it at 0, 1, and 3 months as per the vaccination for that particular vaccine. So you can start it immediately. You do not have to wait. So that's the good thing. So we usually use hepatitis B surface antigen for screening. And most of the time, we don't go into checking whether you have positive antibodies to either C or E. So that's what we do in our program. So you have, as long as we know your hepatitis B surface antigen, we can actually set the vaccine the very same day. Next.
Yeah, thank you so much, Dr. In addition to that, this is a repeated question, and probably to just clarify, someone called Anthony is wondering how long is hepatitis B treatment?
Okay, and I'm going to keep stressing, Anthony, hepatitis B treatment does not stop, because if you stop, you get a flare of acute hepatitis. So you continue with, that's why it is so important, and I must stress this, that you must be sure that the patient must start on treatment. In a lot of cases, as a physician, I'm referred to patients who have been started on treatment elsewhere, and they did not follow the algorithm to check in eligibility of treatment. So it's very, very critical to make sure that you start the patient based on eligibility, because this is a lifelong treatment. You're not going to interrupt the treatment. So please be aware that you must consult if you're the one going to start on treatment, and you must satisfy the eligibility criteria. Otherwise, as a physician, I cannot stop it once you've started it. So be very careful, consult, and make sure you are very careful about the idea of starting the treatment.
So thank you so much, Dr. And the same Anthony was just wondering whether there's possibility of having discordance in hepatitis B related, now that we have discordance in HIV space. Please respond.
So we haven't seen that yet in studies. And I always say hepatitis B and C transmission is actually, your risk of transmission is higher than even HIV. So you must be very careful. You must use protection, because we haven't seen a lot of discordancy. All we just see is probably a waiting period while you seroconvert hepatitis B. But we haven't seen the genetic markers like in HIV, which actually promote patients from not having the infection with exposure to HIV. So yes, this might exist, but we don't have a lot of data on that currently.
Thanks. Opportunity for members to start research and be able to answer some of these questions. I have Ronald on the call. Ronald is a practicing dentist, and he's been practicing dentist for 5 years, and he has never been tested nor vaccinated for hepatitis B. Should Ronald be worried?
If I was Ronald, as a healthcare worker, especially as a dentist, anybody working in the medical field or dental field, yes, you should be worried, because we do use needles in dentistry to inject both local and treatment, and we do pull out bones and drill, and any of this can miss and cut your own hand. So yes, you really should get the hepatitis B vaccine, and all healthcare workers listening should really want to be vaccinated once, and that gives you a long, durable protection. So please, yes, I would advocate for you to be vaccinated.
Yeah, thank you, Dr. I know we are learning a lot from the HIV space, and the fact that the regimens we are using for hepatitis B are also some of the regimens that are being used in HIV. Kevin is asking, can a client be prescribed PEP of TDF3TC to prevent transmission of hepatitis B virus?
So the answer to that is easily yes. If you don't take the treatment well, you can get resistance. That does happen. And that's why we talked about the first line, preferred first line, and alternative regimens. Usually tenofovir is your first line, but even if you don't do well to it, there's ETV and TAF and other forms of treatment that you can use as second line. But yes, we don't have a lot of drugs for hepatitis B. So we want to make sure that you don't develop resistance to tenofovir or a TB when due to poor adherence. That's why I emphasized when you start on treatment, most of us don't monitor these patients well. They are rarely seen in intensive clinics like CCC. They end up coming to the medical outpatient clinics, but adherence must be emphasized, not to be taken lightly. Because yes, you can develop resistance, and that will mean that you do develop into cirrhosis, and you might have risk of getting into complete liver failure. So you want to avoid that.
Dr. And do we have PEP for hepatitis B?
No, not currently. That's an interesting question. Not currently. So the same things I do as I say, please protect yourself. Again, usually if you use barrier protection, that is very effective to preventing hepatitis B. So be very careful about it. So that's really important. Hello?
Oh, thank you so much, Dr. Another question from John. John is just wondering, for married couples whose one is surface antigen positive, what are some of the protection messages that we need to pass to such couples?
You must really use barrier protection, and the partner must really be on treatment if possible to avoid to prevent transmission. And I would take the positive partner through all the eligibility criteria. But we also have to just tell them to use barrier protection as much as possible all the time to avoid getting hepatitis B transmission, because that's very hard to prevent any other way. So that's really important. Once you're on treatment and we monitor your progress, that means that your risk of transmission goes lower as a partner, as a person who is positive. So that's usually helpful. But again, you cannot relax, because we cannot advocate for you to have intimacy without protection if you do know your partner is still on treatment and is positive.
Thank you so much, Dr. And I've seen a question from John, and I think it's important to just clarify with regards to the options that have been provided by the WHO. And John is asking, for the non-pregnant mothers who cannot afford HBV DNA and their hepatitis surface antigen positive, how do you manage them? Please clarify.
I'll go back to repeat again. If you can't, most of us can't afford the HBV DNA, so that's really important. So you want to make sure you can at least do a hemogram where you have the platelet count, and you can do at the AST level, and then you can calculate the APRI score. With that, you can use the APRI score to determine whether you'll put them on treatment or not. But remember, if you are a pregnant mother, I will start you on prophylaxis to avoid you transmitting to your baby if you don't qualify for treatment. So either way, you will get some form of treatment, either for yourself or to prevent transmission to your baby as a pregnant woman. So you will first start with the prophylaxis as you try to get the platelet and the LT level, so that you determine whether this mother can continue treatment later on or stops after delivery or after completing the infant's HPV vaccination series. So please, there's a way to give treatment. It's not only hepatitis B DNA. Please try to get a platelet count and a AST level at least.
And thank you so much, Dr. I've seen an interesting question, and I've once experienced this somewhere that I'll not mention. So this is Francis, and Francis is wondering, can you place a patient with hepatitis B in a room with other patients? Like, do they need isolation once they've been confirmed to be hepatitis B patients?
Sorry, say that again. I didn't get the question, sorry.
Someone is wondering whether you can place hepatitis B patients together with other patients, or they need to be isolated.
Okay, good. Okay, well, you must remember, as I pointed out, most of this transmission is through infected blood or body fluids. Not sweat. No, not sweat. As someone has just asked, no. It's body fluids, like I told you, placental fluids, and such things. So not sweat and not body fluid. There's not saliva. So yes, you can put them in people in the same room. They do not transmit droplets. When you're isolating, you are worried about droplet transmission, like COVID, like tuberculosis. That is where you worry about droplet, about putting people in an isolation room, but not in this case. No, it's the same way we don't isolate patients with HIV away in their own room, away from other patients. We don't do that. Please understand that this is blood-to-blood transmission or placental to blood transmission and such things, not through sweat, not through hugging, and definitely not, as far as I know, through saliva, even kissing. Yes, so that's very important.
Yeah, thank you so much, Dr. There are quite a number of questions. We had like over 100 questions that are just coming in. But just before we proceed with that, I know we have discussed issues around when to stop treatment, but Maureen is a little bit concerned, specifically for maternal prophylaxis. If you start a maternal prophylaxis, when should you stop it, considering that we start maternal prophylaxis based on surface antigen positivity in the absence of DNA? To you, Dr.
Yes, so like I emphasized with the WHO screening, that's a good question. Since you've done hepatitis B surface antigen, as I pointed out, if you've verified that that mother does not need treatment, if you've done the API score or you've done the DNA level or you've done an LT that's persistently high, if they don't qualify, and it's LT, not ST. I think someone has just said ST. It's persistently high LT, and that's usually over a time period like above 3 months or so, 6 months. So if that's one of the criteria I've looked at, and the mother does not need treatment, and her liver is stable, she probably, it might be probably something that you can't even tell whether it's an acute infection, but she's stable, and the liver is not involved. So you can, as I've said, for that scenario, once the baby is delivered, the period of risk is over. So you need to make sure you continue the prophylaxis until the baby has gotten all the vaccine series. All of them have been completed. Then that's when you can stop. So that's really important, either after delivery or preferably after the infant has gotten all the vaccine series. Then you can stop, because you are not giving it for treatment for the mother. The mother is stable. She's not having liver cirrhosis. So you're not worried about her, and you can stop and monitor her closely over time. Remember, when you have a hepatitis B patient, you should still have them monitored in the clinic later on, so that you make sure if they deteriorate, you are able to now do something. So someone who is hepatitis B surface antigen positive and does not qualify for treatment, does not go home and get discharged from the clinic, this is somebody you want to follow up maybe once every 6 months or once a year, just to follow up and see how they're doing, so that you make sure they are well. Thank you.
Yeah, thank you so much, Dr. Ari. There's another question that is asking in terms of hepatitis B and TB, and this is what the question says.
Sorry?
Sorry,
Hepatitis B and TB.
Yes.
So luckily,
managing
TB,
a patient, how do you approach a TB treatment on the background of hepatitis B infection?
So again, that's
with,
a complex
with
patient.
drug-sensitive TB and DRTB.
That's a complex case patient. So I'd want to probably refer such a patient to a place with a medical officer or a physician at least, or a pediatrician. That's a complicated patient. But normally the drug-drug interactions are not an issue, because you're using tenofovir with or without lamivudine, which don't cause issues with the liver. I'd be more worried if you're on a protease inhibitor or you're on an INSTI like dolutegravir, where rifampicin-based anti-TB would reduce the levels of the protease inhibitor or the INSTI like dolutegravir. But in this case, you're not using either of those. So there's no drug-drug interaction with tenofovir or etecavir or your lamivudine and emtricitabine. So you can safely give that. What you need to monitor for, because this patient may have drug-induced liver toxicity from the anti-TPs, you want to make sure you monitor the liver function tests very closely. So that's really key. Also, make sure before you start the TB treatment, assess quickly if this patient needs treatment for hepatitis B, because there may be some liver changes that come in with the use of the anti-TPs, especially with the AST, and the LT. So you want to be aware of that. So that's really critical. But again, try to have such a patient with such comorbidities managed in a scenario where they can get access to a specialist in case of complications.
Thank you, Dr. There's a question whereby there are some patients who may have been started on hepatitis B treatment without checking on eligibility, whether they are eligible for treatment or not. So with this awareness, someone is asking, should they still continue with the lifelong treatment? And probably they did not qualify to be initiated on treatment. What will be your response?
That's a good question. I have such patients who are referred to me all the time in my hospital. Most of the times I take time and go through their history carefully, look for comorbidities. Remember, you have to do a total medical history, look for comorbidities, look for any risks that they have that should be mentioned will be on treatment, and then also just monitor them carefully. So that's a big dilemma I have in a lot of cases. Most of the times I just continue the treatment and watch them carefully. So I want to remind people, please remember the eligibility criteria, including clinical reasons, before you start a patient. Not everybody who has hepatitis B positive antigen needs to be started on treatment. Remember, some of them could be acute, so you don't need to treat them. So you just must look carefully for signs of chronic liver disease. So please let us all be careful, because once you've started treatment, it's very hard for me to judge whether the patient really qualified or has improved after starting treatment. And if I stop, they may have a flare. So that's one of the risky things that we have to think about. Remember, the acute flare of hepatitis might actually cause fulminant hepatitis and liver failure and can kill the patient. So very, very important. Just adding to that as I finish is, there's a question about special clinics to refer cases. Well, most of the clinics with medical officers and consultants can manage a patient with hepatitis, but the specialized management is usually under gastroenterologists, who are specialized physicians who manage the liver. But in most cases, a pediatrician, a physician, even a medical officer can safely, if they know the guidelines, can safely manage a patient with hepatitis. And this patient should really be followed up in the medical outpatient clinic in such circumstances.
Thanks, Dr. There are quite some interesting cases here whereby one says that they had a patient who was female who was tested positive for hepatitis B. She did not do any hepatitis B management related, neither was she treated. But after delivery, the baby did not get the vaccine. However, after 6 months, when the female patient came back, she was negative. Does it mean she's now free of the virus?
Yeah, remember the definition of chronic hepatitis B? Chronic hepatitis B is defined when you have a persistence of hepatitis B surface antigen for more than 6 months. So that's what you want to look out for. So, like I said, a lot of the times you test, you might be a patient who has just recently acquired hepatitis B. So if it disappears before 6 months, that patient had acute hepatitis B infection and successfully was seroconverted, and the disease relapsed and did not go into chronicity. So yes, no need to worry. So that's the thing that we see in a lot of cases. Only about 10 to 15% will go into chronic hepatitis B, and those are the ones we need to treat. Not everyone with acute hepatitis B infection. But then remember, it's not very easy for you to know when the patient was infected with hepatitis B with a single surface antigen test. So if you can't do the other follow-up antibody tests and hepatitis E test, antigen test, then you must look for evidence of chronic disease or comorbidities that would make you put the patient on treatment regardless. Thank you.
Thanks, Dr. One more clarification with regards to the vaccine. Someone is asking, for those vaccinated against hepatitis B, are they likely to still get infected with hepatitis B virus? Maybe you can explain in terms of how long does the vaccine provide immunity and whether they still need to be vaccinated again. To you, Dr.
So if you're getting the hepatitis B vaccine, we know it gives you a durable. Studies have shown it goes more than 10, 15 years as of now. So durable means you only need to be vaccinated once currently under our guidelines. So it gives you quite a long protection, and there's no need to revaccinate with current studies that are going on past 20 years. So it's really durable, and that's one of the things you must note. So yes, it does protect you against getting hepatitis B, so that the antibodies are alerted in case you get exposure to a new antigen with hepatitis B. The immune system moves quickly to destroy it before it has a foothold in your body. So that's the use of getting vaccinated. So yes, it's really important to do that. It does protect you, and for a durable duration.
Thank you, Daktari. And to Victor, we are in the triple elimination space, and Victor wants to just get clarification on when to give immunoglobulin to treatment to a sero-exposed baby. I know it is coming up in our guidelines, but Victor is keen to just hear about it now.
Yeah, so that I think the guidelines will answer that question totally. I'm not a pediatrician, so I won't go into the details of that, but I'll just refer back to the same guidelines that for preventing when you are intervening for infants, it's one of the things that we give. If you have the resources to give a immunoglobulin that helps prevent the transmission to the infant. So I won't go into a lot of details because that's not really my field, but yes, it's really important. And it's one of the things that we look to be able to do in Kenya as one of the routine vaccinations or ways of preventing hepatitis B in infants and children. So sorry, I can't go into more detail because I'm not an expert, total expert in the vaccination for children. So I don't want to go I'll be misleading you on that.
Yeah, thank you so much, Daktari. For the next 3 minutes, we're just going to look through some of the quick fire questions because time is not on our side. But as we do that, I know Regina was still asking issues around the neonates born of positive mothers, which Daktari has already explained. And other questions, sorry, I'm just trying to run through to see whether there's something else that we need to capture in our presentation that is.
Yeah, just to explain, yes, if your partner is positive, it would be really good for you to check that you're whether infected or not and then get the vaccine. So that would really be important. So yes, if your partner is positive, it would really be good for you. If you're sure, if it's tested and you have found that you're negative, vaccination would really be important for you. That's a good point, Joel.
There's one more question from someone who is just asking whether it makes financial sense to vaccinate all adults who test hepatitis negative without checking whether they already have immunity.
Yes, you know what? Yes, that's a good question. A lot of studies have actually used the same basis of just doing a single hepatitis B test and vaccinating. And it does make a population, it makes sense at a population level because the test, if you go further to test people whether they're immune or not, even with a negative hepatitis, that may be too expensive and just mess it up. But if you look at the prevalence of hepatitis B virus in Kenya, it would really protect the 90% or 95% who don't have hepatitis B virus, and would really help us even just try to reduce the prevalence of hepatitis B. So yes, for me, mass vaccination for hepatitis B would be a very cost-effective way to go to reducing transmission of hepatitis in Kenya. So yes, and no, we can't get the hepatitis B vaccine for adults in our MCH. Please don't go get the one for the children. That's not the one we use in adults, please. So don't go to the MCH and ask the nurse for a vaccine for adults. It's not there. The vaccine for adults is usually, right now it's commercial. It's bought from most private health facilities. So it's not something you can just walk in and access in the public facilities for now. But there are places you can get it, like the airport vaccination centers for people who need it. Usually that's where you can go and buy it and be vaccinated. Again, the vaccine for children is not the same for adults. So please do not go and harass the poor nurses in MCH. On a lighter note.
Yeah, thanks. I know one of the participants was just wondering whether there's treatment for hepatitis C. Yes, we have treatment for hepatitis C, and we take the treatment for a period of 3 months. But one more interesting question just before we close the session is, there's quite a number of hepatitis C, hepatitis B co-infections among some of the populations, and the treatment regimens are different. So how do you manage a patient with hepatitis B, hepatitis C co-infection? Thanks, Doctor.
Like I talked briefly about it, it's complicated, but before you start the the medications for hepatitis C, you must start on hepatitis B treatment. And when you complete the 3 months, as you said, of hepatitis C treatment, you must extend treatment for hepatitis B. That is to prevent a flare, especially if you're hepatitis B positive. If you're eligible for treatment, then you will take the treatment for hepatitis B lifelong, like I said, as you take the 3 months of hepatitis C treatment. So that's how you approach it. But if you're not eligible for treatment, you must get a dose of treatment before you start the HCV treatment, and then after for a few weeks, and then you can stop. This is to prevent the flare of hepatitis B. Thank you.
Thanks so much, Dr. I know when it comes to hepatitis management, we cannot really even afford to respond to all of the questions. However, I have indicated VHSTI email address on the chat so that should you have any questions, should you need additional facilitation at facility level or at the county level, please write to vhsti@nascop.or.ke. And I just want to thank Dr. Wagude, who's been kind enough to just provide his time and also ensure that he clarifies most of our questions on the chat. I want to let you know that this webinar will not have been possible without the support of Kenyatta National Hospital that is based within the URN, and also the support from Gilead Sciences, inclusive through Philips Therapeutics, which are the local partner in the country. For all the panelists and the presenters, I want to thank you so much for your time for this. And should you have any question, do not hesitate to contact vhsti@nascop.or.ke. I have seen some of the questions in relation to policy. We are working on the policy-related issues to ensure that we are able to handle hepatitis-related matters in the country, and also ensure that all the healthcare providers have been capacity built to manage viral hepatitis efficiently. So thank you so much, everyone. We wish to end the call now. And just to remind you that the World Hepatitis Day is 28th of July, and we are celebrating this day in Mombasa County. However, you're welcome to post, tweet, retweet, and do anything within your capacity to spread word around hepatitis. Asanteni sana, till next time, bye.